Very accentuated. Right atrium, right ventricle, left atrium, left ventricle. Okay. Lungs. What is this called?
Your tricuspid.
Tricuspid. Why?
There's
Three
three
lobes on the
valves.
right side of the lung. It's the easiest way to remember.
The what?
3 lobes on the right side of the lung. Right
Oh.
lung is 3 lobes. Bicuspid, 2 lobes on the left side of the lung. Blood flow, we're all familiar with it. Pulmonary arteries, pulmonary veins. What's the artery? Is that carried deoxygenated or oxygenated?
Deoxygenated.
Pulmonary vein, oxygenated blood. Delivers into the left atrium. Delivers into the left ventricle up to the aorta. This is the brachiocephalic artery supplying the head, neck, and the opposite arm. Left. This is the left internal carotid supplying the neck. And this is the subclavian, opposite supplying this left arm. Subclavian. You hear the term chemoreceptors. Those are important in monitoring oxygen levels in the blood. That's right here. Chemoreceptors are right here. They're located along the carotid as well. It's important to know that because if there are any changes in oxygenation, the first thing to know is the brain. That's going to send signals down the phrenic nerve, down the internal of the thoracic cavity, letting this heart know it needs to increase heart rate, increase blood pressure, stuff like that. The vagus nerve also helps with that. Conductivity. So this is circulation. This is conductivity. All the same heart. Right atrium. Right ventricle. Left ventricle. Left atrium. These are all important things here, terms to remember. This is the sinoatrial node. This is still covering anatomy. SA node, sinoatrial. Is the primary pacemaker. These are called pacemakers of the heart. Sinoatrial primary. AV, atrioventricular. It's easy to remember, in between the atrium and the ventricles. The secondary. Second pacemaker. You have what you call the Purkinje fibers. Purkinje fibers. Tertiary or third. I'm not going to talk about intrinsic rates right now, but you have also anatomical structures in the heart. The bundle of His, this is important to know. Bundle of His, bundle of His, either way. So we start looking at automaticity. These are other terms. And once you can once you know this, you can troubleshoot what's wrong with the patient. I mean, if you're reading the question and you're like, I have no clue what's going on. If you go back to this, you can figure it out. So automaticity. Conductivity. Automaticity is the spontaneous depolarization or impulse sent from the pacemaker from a pacemaker. Conductivity is the ability for electrical fibers to conduct that impulse from that. So these are electrically charged fibers. These pathways will never change. It's the same with every heart. You have just electrical fibers running around into the atrium and ventricles of the heart. And this is a myocyte, cardiomyocyte, cardiac muscle cell. That's what this is. Each and every little part of this heart is filled with electrically charged cardiomyocytes. And contractility. Ability for heart to contract, of heart to contract. Because you can have electrical activity without cardiac contractility, if that makes sense. PEA is what's that called? You can see it on a heart monitor, but you won't feel a pulse. They're dead. Okay. And this is all innervated from, parasympathetic and sympathetic activities. So this is automatically going. That's why it's automaticity. We can't do anything to change that until you die. The heart's going to keep beating. Conductivity, anatomical changes, stuff like that can change how this conducts. Contractility is just the strength of your heart. You start thinking like ejection fraction and stuff like that. Okay. Is this your computer? Nice. It is. Look at that. That's pretty cool. Okay. So we're going to talk about, let me erase these. And she's going to be able to pause that and zoom in when she wants. Erase these. Get a little bit more room. Rhythms of atrial origin. This is all electrical activity now. Atrial origin. We're going to start talking about ECGs, stuff like that. I don't think it's that important. Whose book is it? What chapter are we in? 30s somewhere? I haven't opened the book.
I think it's 30.
That's all right. Okay. Yeah, we're on 34. Okay. I'm going to see if it covers. Yep, it does. Okay. Before this, we're going to talk about cameras. Neck, shoulders.
Is it cameras?
Yep. That's how we read ECGs. This is a human body. He's a male with gynecomastia. You heard of 3-lead, easy lead? So 3-lead, easy lead placement. Left arm is one sticker, right arm is the other sticker, left abdomen or leg is the ground or the other sticker you put on. And what these wires do, they go into a monitor and they read their waveform, whatever. The left lead is going to read everything at this angle. Your heart's right here. Mediastinal. Everything's going to read at that angle. Left goes towards the right foot. This one is the most important one. Sorry, I should label these. Lead 1, lead 2, lead 3. This right one is one of the most important ones. Because it's going to read this at this angle. This is most important because this is the way the charge depolarizes. Okay, and sorry for not writing, but depolarization, dipole is what I'm going to call it, is the act of conduction. Conduction act. And repole is the opposite. Since this is electricity, we have to have a charge. Repolarization is just recharging. Repole is just recharging. We'll get to that in a second. We got to talk about these cameras because it's in the book. Lead 3 is mainly going to read inferior part of the heart at the upright angle. So lead 3 is going to read this way. Lead 1 is going to read from left down, and lead 2 is going to read the path of conduction. This is going to give you all 3 different patterns. So you have 3 different waveforms. That's all these are, just cameras. Okay? They're just little cameras. And it does mention 12 leads, so we're going to just go over placement of the 12 lead. In the book, it goes over it. I didn't think it'd be that extensive, but I wasn't planning on going over this. 12 lead, simple. Mediastinal. You have a V, correct me if I'm wrong, V1, V2, Ashley?
Yeah.
Left arm is V2? Okay. And we're going to go
V1.
second intercostal space, V1, V2, left and right side of the sternal border. V3 is, I believe, is a third. You have to read third intercostal space, left at the border. Fourth is, sorry, it's not that wide. Very close. Midclavicular line, important to remember. V4 is going to be right there, midclavicular line, at the fifth intercostal space. V5. V5 is going to be lateral of that, same plane, lateral of the V4. V6 is going to go mid-axillary under the armpit. So 1, 2, 3, 4, 5, and 6 right there. These are all different camera angles in the heart. Oh yeah, and you have one for each limb, don't you?
Okay, because you still have the 3 lead on.
Yeah, you have one for each limb. You can put that on the distal arms, up at the shoulders. Distal legs are up at the hips. All camera angles. These limb leads act as like your easy lead, so it's going to read the same way. Like left arm's going to read to the right, right arm's going to lead to the left. The legs are going to read up. And you're going to see in this order on the EKG strip. Very important, and this is something I would probably take a picture of and memorize. I'm about to put down. ABF, ABL, ABR, V1, V2, V3, V4, V5, V6. And then you're going to have an extra reading down here. It's usually lead 2. Then you're going to see a whole bunch of rhythms. little rhythms, all coming from different angles of the heart. And then we'll talk about rhythms after this. So let's think about it. V1 is going to be good. It's reading down into the heart. Your heart's right here. It's going to be reading down into the heart. V2, surprisingly, follows the conductivity pattern better than V1, in my opinion. Conductivity pattern is this way. So when this depolarizes, when this SA node fires off, this camera's reading that. This camera's reading that. That's what you see, these wave patterns. So when this SA node depolarizes, you're going to see a bloop in the waveform. Make sense? All these little stickers are going to read a bloop in a waveform. Just like that. Basic camera stuff. We don't need to, as nurses, we don't need to interpret these, and well, we do, but we don't have to diagnose these. We can be able to say, oh, they're in a sinus rhythm off of this. All right, rating ECG patterns. You want to go over physiology? Sodium, potassium, magnesium, calcium.
After, maybe if we have time after the.
Okay. Okay. I think physiology is important too with treating, but we can go over that after. Just remember sodium, potassium, calcium, magnesium. That's going to interact with your waves. So atrial origin. Atrial origin. You can even put sino. Okay, I'm going to leave this up. I'm going to refer to it. Everything's originating from this pacemaker, the sinoatrial pacemaker. We're talking about atrial rhythms. Okay, so when we have a depolarization from the SA node, it's sinoatrial rhythm. We're going to have sinus, normal. This is normal sinus rhythm. We're going to have bradycardia. We're going to have tachycardia, sinus bradycardia, sinus tachycardia, and normal sinus rhythm. We're also going to have AFib. Now this is an atrial rhythm. This is why I like calling it atrial instead of sinoatrial. But, AFib, a flutter. Remember Brady? Is anything less than 60? Less than 60. More than 100 for a tachy. So with the sinus rhythm, you're going to have this normal depolarization from the SA node to the AV junction to the bundle of Fis and to the Purkinje fibers. So we're going to have a waveform that looks like this. I'm going to go over each wave. I don't know why I drew that so high. Notice the T wave is bigger. This is called your P wave. This is called your QRS complex. This is called your T wave. P wave represents atrial depolarization. Atrial depol. From the SA node firing off, the atrium is depolarizing, not necessarily contracting, but it's depolarizing. Okay? That's what this is, the P wave. And we know the heart doesn't work as one unit. You have the AV node to go through. And what this guy does, the AV node, is he slows down the impulse. His job is to slow down the impulse. Slows impulse. So this is going to fire off. We have the P wave. And this time it takes for this AV node, that delay is called the PR interval. PR interval. That's the delay of the AV node. Delay of AV node. That's good. This is a good thing. Normal PR, if you look in the book, I think Ashley said it's 0.12 to 0.20 seconds. That's your PR. The QRS represents the QRS complex, is what it's called. Represents ventricular depolarization. So we have our atrial depolarization. This time from atrial depolarization to the beginning of the QRS is the PR interval, representing this delay in conduction at the AV node. Then we have this conduction going through the Purkinje fibers around the ventricles. That's the ventricular depolarization. Normal time for that is 0.08 to 0.12 seconds, the QRS complex. Then we have the T wave. The T wave, the T wave represents ventricular repolarization. Repolarization, very important. You can't have a depolarization without repolarization. Discharge without recharge doesn't happen. You might ask, okay, the SA node fired off, the atrium is depolarized. Where does that repolarize? It happens in the QRS. You won't see it. While this is being fired off throughout the ventricles, this atrium is repolarizing. And anatomically, the atrium is significantly smaller than the ventricles, so you won't even see that wave in there. Never see it. Just know that they are repolarizing in the QRS complex. Vent repol is important in the sense, how long does it take for the heart to recharge? So from the end of ventricular depolarization to the time it takes for full repolarization, that's important, full repolarization, it varies, and I'll give you a couple scenarios. It's usually below 0.40. Medications, cardism, beta blockers. Any beta-1 antagonist will lengthen the time it takes for this to repolarize. And that's important to know because of this. I'll show you. Let's draw another QRS rhythm here. Because if this is lengthened, more than 0.40, this T wave is going to be closer to this P wave, and we don't like that. I'll tell you why. We don't like that because this T wave, if you imagine it split in half. So this is a T wave. T wave. Imagine it split in half. We have what's called the absolute refractory period. Absolute refractory. This is important to know. Meaning absolutely no depolarized or conduction can cause an impulse through the heart. No impulse can cause another contraction, basically. A pacemaker spike, you hit in the chest with a baseball, anything, it will not cause another one of these, okay? One of these rhythms. However, if you're in the relative refractory period of the T wave, relative refractory, any sense of impulse or depolarization or electrical activity can cause another conduction throughout the heart, and that's a problem. And this is all ventricular, remember? The T wave. So if the heart isn't ready for another impulse, and you pacemaker spike, you're hitting the chest, you cough, hit your chest, that's all electricity. That's force. That can cause what's an ectopic beat, meaning if you cough during this little depolarization, it's repolarizing, not fully, it's going to depolarize, meaning it's going to shoot electricity that way. That you can die from that. You know, people don't think of it, but yeah, you can die because of that. Mm-hmm.
How do I know?
This is a fraction of a millisecond.
Oh, okay.
You know, very unlikely, but yes, people can die. Yeah, people can die from, like, it's not usually a cough, but a pacemaker spike. This is more like when you're trying to cardiovert somebody, stuff like that. Any kind of impulse can cause a weird rhythm to come out of it. It's not good. Okay, so sinus rhythm. You have your P wave, and I'll write this down. Sinus is important. Has a P wave for every QRS, for every QRS. And if you want to make these in the tables, it'd be great. That's a good way to study. So sinus, sinus rhythms, and make a list. P wave for every QRS, QRS for every P wave. Sounds silly, but I'm going to get to it in about 10 minutes. For every P wave. PR, normal. QRS, normal. QRS, normal. That's your sinus rhythm. And depending on how fast it is, it's going to determine if it's Brady or tachy. That makes sense? P wave for every QRS. So we have a P wave for every QRS. We have a QRS for every P wave. The PR is within normal limits. The QRS is within normal limits. There's a sinus rhythm. Oh, I forgot one. R to R. This is going to determine rate, how fast your heart's going. R to R determines heart rate. Not necessarily, heartbeats. Because we're not talking about contractility, we're talking about electrical activity, heart rate. Okay? Let's talk about AFib. Those are your waveforms. I mean, those are your waves and everything you need to know. Every one of these rhythms will have that. So once you get that down, you're good. AFib. Sinus is clear. Everyone is in sinus. Everyone is in normal sinus rhythm. NSR. Should be. It's a normal rhythm. Everyone has it. AFib. This is where we give Coumadin, blood thinners and stuff. Tell you why. Back to the circulation. This is why we give blood thinners. In AFib, this depolarization is ineffective. We have multiple sites of pacemakers outside of the SA node firing off at the same time. This is due to aged heart, weakened, damaged heart, bad vessels, any kind of an ischemic activity. Multiple pacemakers are trying to compensate for this SA node not functioning properly. So your heart, the atrium looks like this. It's literally quivering. Fibrillating is what they call it, AFib. Circulation muddles in the atriums. What happens when you have stasis? Stasis? That's right. Okay, AFib. Very important rhythm. A lot of our people are in it. So, an AFib, because you don't have a primary pacemaker, the SA node, you won't have a P wave. Okay? Your baseline is going to look like this. Oh, hold on, that's too pretty. It's going to look more like, like that. There's no P waves, where a P wave would be nice and round. There's no P wave, it's just kind of fibrillating. You're going to have your QRS, which is your normal QRS. And you should have a T wave, or what resembles a T wave, but it could also be fibrillating. So I'll draw that T wave with little dots. You should have a T wave, but if you don't, it's there. It might even look like a, fibrillating T wave sometimes, like that. But yeah, so you have no P wave, no P. You have your QRS, should be within normal limits, You have a T. So where's this primary pacemaker coming from? Any of these? Yeah, it's any of these. And I'll tell you, this AV node, his job at this point is to stop all of these depolarizations. And he's going to pick and choose. Okay? This AV node, think of him as a bouncer in a club. You hear the analogy, president, vice president, speaker of the house. I like the analogy, people standing outside the club, the bouncer, and people in the club. This bouncer is going to pick and choose who he wants. He says, okay, you. So you're going to have what we call an irregular rhythm. You ever feel someone with a AFib? It's not regular. It's like boom, 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 boom. It's just irregular. That's the characteristic of AFib. Irregularly. You can remember this. Irregularly, irregular.
T wave was doing again? Sorry.
Oh, you might have a T wave.
Okay.
Yeah, it's just fibrillating. Might even be flat. Irregularly, irregular. Irregularly, because there's no P. There's no P anywhere. And always remember, a P wave precedes the QRS, like in the picture. And irregular because the R to R's, let's say this is point, I don't know, 6. This is point 2. This is point 4. It's not regular. So heart rate, it's going to be bouncy.
I have a question.
Yeah.
So when we started the AFib, you said you're still in regular sinus rhythm.
No. We're in a atrial rhythm.
Okay.
AFib, I'm going to erase this because some textbooks say sino-atrial origin. It's an atrial origin. I like that better.
Okay. So they all start in the atrium.
It's in the atrium. These rhythms start in the atrium. Yeah, so you won't have a P wave, but you will have QRSs, and they are not regular in pattern. So on your chart, underneath your sinus rhythm, you have AFib. Get the list. No P wave, no P. You have a QRS within normal limits, hopefully. Look for T. You will have a QT, you should. Oh. And then the sinus rhythm. I didn't tell you this. Yeah, I did. I went over QT. It's usually under 0.4.
Right.
And your QT. That's AFib. Typically, they're tachycardic, unless they're controlled. If they're uncontrolled AFib, they're typically tachycardic and blood pressure's out of whack. Make sure they're taking their Coumadin, carvedilol, cardizem. Can you convert these people? Yes, via medication. or cardioversion. A flutter is my favorite rhythm. A flutter, similar to a fib, but you're going to have what's called shark tooth or saw-like patterns. What are these, Mallory? What is that? You got
Okay. I was like, God help me. I'm just trying not to cough so I don't die.
You better not cough. You're gonna die. Uh-oh. You have a charger?
Mine's right there, but I don't think it's the same for your computer.
Yeah, it's different. Sorry, this is taking a while for you all. Chips. Teaching you all cardiology.
Yeah, just take mine out.
There we go. Okay, it's
Well, you don't have to rush everything. We can do this again.
It's all right. A flutter, unlike a fib, it's not jaggy and crappy looking. It's nice sawtooth pattern. So sawtooth pattern. Are these P waves? No, they're not P waves. I'm going to draw a small version of that heart over there. Tell you what's going on. There's two etiologies. There's two etiologies to a flutter. That's your conduction. One is a pacemaker, one single ectopic meaning other than normal. Ectopic pacemaker has taken over the SA node. And typically this pacemaker is surrounded by electrical fibers. And it's going to fire off at a faster rate, trying to take over this SA node. And that's what this is. He's just firing, doop, 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 doop. The other one, this one, and both of them really need to be controlled by a surgical intervention, EP lab. The other one I like is called a recirc, a flutter, and I think that's what's covered in the book is recirculation, a flutter. You have an ectopic origin, and it's surrounded by your electrical fibers in a circle right outside the SA node. So it's literally right by the SA node. It's literally right outside the SA node. That's your SA. It'd be right here. And the electrical fibers are leading back into the SA. So when this thing fires off, it's going to go like this. That's what you see. Now, the whole bouncer thing applies to this like it does a fib. It's going to pick and choose the impulses it wants. So this is shooting, it can be 200 impulses a minute. Do. This QRS, or this AV node, is going to pick and choose which impulses it wants. And that's where you get your QRSs. Two things about a flutter. You can have a regular R to R. So you might have a regular, or you might have it irregular. So with a flutter, make your box, make your list. We have regular, R to R, or irregular, R to R. And you can start going into, it's 3 to 1 conduction, meaning you don't have to write this down, but this is why it's called irregular. For every 3 impulses, there's 1 QRS. 1, 2, 3, 1. 1, 2, 3, 3 to 1. For example, this one is 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3. So this would be an irregular AFib. Even though these two are normal, it's an irregular AFib. You can have a normal QRS, Ashley, what's normal QRS limits?
Normal QRS.
Mhm.
Limits. P waves, oh, the time?
Mhm.
8 to, or 12 to 20.
That's PR. 0.08 to 0.12.
Oh, yeah.
That's QRS.
12.
You're next.
A
Hey, Flutter.
You can show you ways to count them too.
With this, usually you're gonna have to go to EP Lab to get this taken care of. People can live with it.
What's EP lab?
Electrophysiology. You're gonna go in and burn this, cauterize these electrical fibers so it doesn't cause a recirc. That's what EP Lab does.
Is that what they sometimes call an ablation?
Yeah.
Okay.
Yep. Okay, that's AFib, A-flutter. You're going to see AFib a lot more often than you will see A-flutter. It's not very often you see that. The other one I'm going to go over is SVT, and then we'll start going over junction. We don't go over junctional. I don't think it's covered. But we will go over hypertrophy and ectopics for sure. Oh, yeah, we don't go over junctional. Excuse me. So SVT is anything above 150. It's your sinus rhythm. Very fast. P wave, P wave, P wave, P wave. QRS, 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 and T, T, T. Remember, P wave precedes QRS. T wave is the wave after QRS. This is like above a rate of 150. If they're symptomatic, dizziness, confusion, stuff like that, you're going to want to cardiovert them. If they're not, is it 150? Yeah, technically it was 180.
180.
180. 180. Above 180 is called SVT. And sometimes you'll barely even see this T wave. You'll look at it like this. It can be this fast. If you see this on the monitor, they've got some serious issues. Yeah. Shortness of breath, dizziness, confusion. At this rate, they're not perfusing. That blood doesn't have time to go through the ventricles effectively. This is pretty bad. This will not last forever. So they're in respiratory compromise. You're going to be looking at that. You're trying to compensate for something, obviously, so you got to figure out what's going on and treat it. If they're not symptomatic and they just started it, adenosine is your drug. You might have learned that in peds, adenosine.
Did we learn it or were we tested on it? Those are two different things.
So adenosine, is your drug for non-symptomatic, for a asymptomatic SVT. And then cardioversion is when they are symptomatic. Cardioversion is simply putting on the patches and shocking them. Where do you shock them? Anywhere but the what of the T wave? Refractory? Relative? You can't shock in the relative refractory period. Okay? So that's SVT. You'll see that a lot.
I feel like I wouldn't want to have that job. You know when you're playing those games where you have to like hit the thing right on it?
Well, the nice thing, yeah, exactly.
It aligns you with the right rhythm to do it.
Thank God.
So I think it's a pacing thing or sensing.
You pace it. The jewels, like there's a button to push where you synchronize cardioverse. So it's gonna be
Synchronized. That's what it is.
It's gonna be synchronized with the wave.
Yeah, it synchronizes with the QRS.
You said anywhere but the
Relative.
relative
So absolute refractory period, absolutely no impulse conduction will cause an issue. Relative, relatively an issue will occur. Okay, and let's go over ventricular rhythms, which they're all bad. if your pacemaker in the heart, the SA node, due to age, trauma, injury, ischemia, fails, the AV node will take over, right? If these pacemakers all fail in the atrium, and if it's not at least, I'll show you. If it doesn't originate in the atrium, the AV node will take over. And I'm not going to talk about intrinsic rates because that's a little confusing for people who haven't done this for a while. AV junction will take over. This will become your primary pacemaker. If this fails, Purkinje fibers will become the primary pacemaker. So we're going to talk about when these become the primary pacemaker.
The
Purkinjes, yep. So what are we going to have? Are we going to have a P wave?
No,
Why not?
it's not firing in the atrium.
Okay, very good. And if this depolarizes right here, it's going to take longer for this to come all the way around in the ventricles versus when it's a straight shot down. So what's going to happen? We have a wide QRS. The wider, this is important to know, the wider your QRS, the worse your patient is. So if it's above 0.12, you've got bad shit going on. It's not good. If you have a normal sinus rhythm, but the QRS is wide, QRS is above 0.12, that can happen. It's common. There may be a block right here at the bundle of His. That's usually where it is. It's called a bundle branch block. So anything with the QRS wider than 0.12 is called a bundle branch block. So this rhythm right here will be normal sinus rhythm with bundle branch block because it is a symptom of a widened QRS. You're not saying this is a bundle branch block rhythm. This is a normal sinus rhythm with a bundle branch block. So that's what this is. It's a wide QRS. So ventricular rhythms. And are they going to be regular? Sometimes, maybe. Maybe the heart's compensating well. Ventricular rhythms. Are they regular R to R's? Maybe.
Doing really good.
P wave? Nope. Non-existent. You won't have a P wave. Nowhere. Anywhere. T wave? Maybe. Because of this widened QRS, once this depolarizes, say example left ventricular origin, this depolarizes, it's going to repolarize right after that. So this widened QRS is going to hide the T wave. Probably won't see it. Maybe.
Would it be possible to see a little one right afterwards?
Maybe. Yeah, for sure. You might see a little one afterwards. T wave? Maybe. But, this stuff becomes not important at this time. This patient is going down quick if they are having this. So the ventricular rhythms, IVR, I would underline IVR, VFib, VTAC, I would underline VFib, I would underline VTAC. Technically asystole is asystole. Underline that one. We'll go over blocks. That'll be our last thing. Okay? These are ventricular rhythms. So a ventricular rhythm, this may be regular. There's no P wave. And you're going to be slow. Typically they're slow. Less than 40 beats per minute. So you're going to say, oh, ventricular bradycardia? No. It's ventricular in origin's already slow. But there is VTAC, so you can't have a fast ventricular rhythm. That's not good either. And I'm going to go over these rhythms here, and then I'm going to go over one more when we cover blocks, and that's third degree. And then we'll be good. IVR, means idioventricular rhythm. We don't know where it's coming from in the ventricles. We just know it's ventricular because of the wide QRS. This doesn't sustain very long. If you see IVR in the patient, expect a code to be happening very shortly. This patient needs a pacemaker, either external or internal implant. Drugs, are they going to affect this patient? Maybe. Atropine. What do you give atropine for? Slow heart rate. How does atropine work? Okay. It acts on the phrenic nerve. Phrenic and vagus nerve. So those are your things. This patient's going to be sick. They're going to tell you, oh, I'm not feeling good. I'm nausea, vomiting, dizziness. They're not perfusing. So you're going to have systematic effects. Kidneys are going to start retaining water. You know, you're going to be sick. VFib. VFib. And I told you to underline IVR because this is called a lethal rhythm. The underlying rhythms are lethal. You see this on the monitor, you need to call somebody quick. Lethal rhythms, these are.
Wait, sorry, all of them are?
Yes.
These, yeah, all these are lethal rhythms. Third degree as well. We'll cover third degree and we cover blocks in a couple minutes. And then we can get out of here. With VFib, very short lesson on this. That's what it looks. That's what it looks like. You see that on monitor. You know, you see that in a TV show. That's not good. What's happening? Remember with AFib, you have lots of pacemakers trying to take over. Same thing in VFib. Lots of them are depolarizing at the same time. So you have your ventricles fibrillating. Do you have any cardiac output? Because the ventricles aren't contracting. That's right. They're dead. You need to start CPR. CPR immediately with VFib. You do CPR and IVR? Okay.
Wait, what's the answer?
If they have a pulse. First thing, first question you should ask.
No,
Do they have a
if
pulse?
you won't.
Yeah, first
You only
question.
do it on V,
First question you should ask: do they have a pulse? Because what am I saying? This is all. It doesn't matter if they don't have a pulse, right?
There's no electrical.
There's no contractions.
Okay.
You can have electrical activity, but no contractility. Yep. VFib, we covered that. VTAC, very cool rhythm. Huh?
Ursula's hair.
Sure, yeah, Ursula's hair.
Whatever.
Little Mermaid. So with VTAC, you're going to have typically a wide QRS. It can be fast enough to where it narrows, which is fine. But you're going to know it as VTAC is wide and fast. Wide because it's ventricular in origin, and fast. 180, 200, 150, it's going to be tachycardic. This patient is not perfusing. The body is trying to compensate. These ventricles are firing off at such a fast rate, it's not allowing blood to fall into the ventricles. So you're going to have low blood pressure if they're awake. Very sick. This, if they don't have a pulse, obviously CPR. But this, you're going to have to shock them. VTAC, going to have wide and fast QRS. Very quick gist of that. CPR if there's no pulse. If there's a pulse, you're going to want to quickly cardiovert them, put them on the patches. Synchronized cardioversion.
What is the difference between
Okay, so the AED is to shock them into a living rhythm, and you don't have to synchronize that.
Okay.
So VFib.
You just shock me.
I mean,
It's
an
gonna tell you-
AED,
they don't
AED.
tell you to shock or not. It's for a layperson that is not reading anything. It's sensing the rhythm and it's going to say shock or don't shock or start CPR.
Now,
Okay.
if it reads this, is it going to tell you to shock? Because this is PEA. If you're doing CPR on somebody and you stop and you look on the monitor, this is the rhythm you see, this is PEA. According to that AED, this is a living rhythm. Okay? That AED is only going to monitor for VFib, VTAC. Some AEDs will synchronize. And what I mean by synchronize is that computer and that machine is going to do this. It's going to shock at ventricular depolarization to reset the heart. Okay? So when you just turn on synchronization, you'll see it before. If you don't have it on, it's just going to be a rhythm. But as soon as you turn it on, boop, boop, arrow's going to show up above those QRSs, and you know it's okay to shock. If you shock without these arrows on, you have a potential of hitting that relative refractory period. But at this point, it
And
wouldn't
then if
matter.
they're in VFib, you're not gonna synchronize. You're gonna
shock. There's nothing to synchronize.
There's nothing to synchronize, and you're not really worrying about the refractory because they're already dying as it is.
Yeah. Good question. How are we right now? Understanding it a little bit?
I mean, it's a lot. But
It is.
especially since I've never learned any of this, but you're doing a better job than reading slides.
Yeah. See, I don't learn.
Yeah.
Yeah, I don't learn with slides. I learn with the whiteboard.
Literally today, I was like,
So asystole, everyone knows that. CPR, easy. CPR, asystole, you can't even shock it. It's not going to do anything to the heart. Asystole, if they're in consistent asystole, even after CPR, epinephrine, amiodarone, all that stuff, these electrical fibers are dead. That patient's dead. If after CPR rounds you don't see a rhythm, physicians will call it usually after 20 minutes. Okay, there's 4 more rhythms we're going to cover real quick. These are your blocks. So remember your blocks. This isn't like bundle branch blocks, you know. We have a first degree. We have a second degree, type 1. Second degree, type 2. These are fun to work with. Third degree, just third degree. Type 1 is also called Winky Bach. Yep, Winky Bach. I don't know how to spell it. You saw that coming. I think that's a K. Yeah.
I think there's an I in there, but it's cool.
Winky Bach. I'll put that right there. Type 2 is most commonly known as Mobitz 2. One more name. Type 1 is also called Mobitz 1. This is the guy who found it, and Mobitz just decided to, decrease confusion. First degree is very easy. First degree, you have your normal sinus rhythm. The only difference, what can you see right now? Well, okay,
Long PR interval.
long PR interval. So you have a sinus rhythm, normal sinus rhythm, with first degree, and it's also called AVB, arterial ventricular block, is what that means. Arterial ventricular block. This delay in PR has to be above 0.20. So So it's above your normal limit of your regular PR. And why is that happening? This delay in conduction, this AV node, remember, is responsible for that delay. There's like a block in conduction. This is small. It'll circumvent or bypass that block in conduction. Athletes have this. It's, non-symptomatic. You will not have symptoms from this. The only thing you need to worry about is what if they're taking a beta blocker. Remember what they do to the heart? That QT is going to elongate. If it creeps closer to this P wave, you look at RMT, or relative refractory period depolarization. So the only thing you have to worry about, if anything, this is absolutely benign. The only thing you need to worry about is that QT. If that QT is elongated, you got to start worrying about this P wave having a conduction at the end of the T wave. That's it. Athletes have this. You won't be on any medications for this. Absolutely benign. First degree atrioventricular block. Now, these are the fun ones. But first degree, if you make your table, it's normal sinus rhythm just with a elongated PR interval. That's all it is. Second degree type 1, Wikibach, we have a fun little pattern. Pretend these QRSs are the same. This is really exaggerated too. So what's happening?
PR interval's getting longer.
Yep. PR interval is getting longer. Okay. So this is when you start thinking. This is your template. So for second degree, type 1, Wikibach, Mobitz 1. Let's go back to our questions. P wave for every QRS. You start looking at blocks. You have to do this in order. P wave for every QRS. Yes. Excuse me. QRS for every P wave. Yes. And it sounds silly, but believe me, it's going to get pretty crazy. And then the other thing I like to look at is, your PR interval is elongating every time. So this one looks normal. So this one, let's say it's 0.17. This one is probably 2.22, a little bit longer than normal, but this one is 0.28. What's going to happen is it's going to reset. Go right to normal again. And the fun little trick about this is it's longer, drop. Got to put the drop on it. Gotta do it too big. Longer, drop. You all see that? It's a Wikibach. PR interval is longer, drop. You don't have a QRS. And it's reset. It's a Wikibach. The PR interval, longer, drop. This is your drop. That's a Wikibach. So you answer your question, is there a P wave for every QRS? Yes. There's a P wave, but there's no QRS. QRS for every P? Oh, I'm missing a QRS. So you know something's wrong here. It's not normal sinus. And then your PR interval elongates. And it can be 3 times, it can be 6 times, it can be 2 times. That's when it's confusing. Is how many times does this elongate before it drops?
I have a question.
Mhm.
So when you say PR interval,
Mhm.
it's from the P wave, start of the P wave,
Beginning of the P wave,
to where is the R, the top of that?
beginning of the QRS.
Okay, so the R is the QRS.
Yeah. So this I didn't go over this because QRS morphology is different, but technically an R wave is the first downward deflection below the baseline. Here's your baseline. The Q wave is the first upward reflection above the baseline, and you notice deflection, reflection, deflection towards the baseline. This is the S wave. This is your Q. This is your R.
So really they should call it RQS.
Sorry, my bad. Q
Okay.
R. Yes.
Okay.
My bad. So if you have something like this, what you have a R, Q, S, and if this was high, you would have an R prime. Confusing? Don't worry about it. Yes.
Erase that little guy.
Yeah. Don't worry about it. But Winky Bach is a fun little rhythm. Be a bastard to diagnose, but what's happening here is your AV block. It's in a certain spot to where it's taking these conductions and it only circumvents that block so many times before it stops. Okay? It's being used and abused, that little thing. Normal, longer, drop. It's a Winky Bach. That's a little, I don't know what you say, bedtime story or whatever, rhyme, give your kids.
Give your patient.
This is type 1, okay? This patient usually isn't symptomatic with treatment. You support, measures, low blood pressure, whatever. He may need a pacemaker. He probably will get a pacemaker. If it's a Friday, he'll get a pacemaker on Monday. It's not too important to intervene. Like I said, symptomatic, maybe. If they are, it's because the heart rhythm's too slow, and what are you going to do? You're going to give them atropine. Might give him pressors with his low blood pressure, but that's treatment for any cardiac issue. Type 2 is a bastard. You have P wave before the QRS. What's after QRS? It's your T. This is a P wave. This is a P wave. T, P wave, P wave, T. Type 2, second degree type 2. Do we have a P wave for every QRS? We have a QRS for every P wave. Yes. We have either an ectopic or etiology coming, delivering a impulse that's not being passed to the AV node, AV block, or we have the SA node firing off and it's not going through. What do you feel when you feel a pulse? What part of this rhythm are we feeling? The QRS. Do we feel these? Nope. So what's missing here is a heartbeat. You're going to be bradycardic. Heart rate's going to be in the 40s. Okay, so what's important for the type 2, second degree type 2, is your PR. And PR, I think, is the most important aspect of all of this. Because if it elongates, what is that? Type 1. Second degree type 1. If it remains the same throughout, but it's missing P waves for every QRS, this is a type 2. So we have P waves, but we don't have a QRS here. So you'll see a whole bunch of little waves without QRSs, and you're like, what the hell is this? So next thing you do, look at PR. If it's normal, PR is 0.12 or whatever, 0.12 to 0.20. That's normal. This is a type 2. So PR is a normal. That's the number one thing in your blocks. PR. Second degree type 2, your PR is normal, but you don't have a P wave. Sorry, you don't have a P wave for every QRS. You have a P wave, but no QRS. So type 2, PR is normal. It's equal throughout. Type 1, PR elongates. Now, third degree, and this patient is more than likely going to be symptomatic. Pacemaker, supportive measures of blood pressure, fluids. Is atropine going to work? Maybe. When you start going into blocks, atropine works on the nerve. This is blocking the nerve. This blocks the conduction. Atropine works on that, but this is blocking atropine from working. So in theory, it's in theory, it will work or it might, or it won't. But more than likely, you're going to be giving atropine. You're going to be on vasopressors for blood pressure, and you're going to need a cardiac pacemaker. If you develop this on a Friday, they'll probably do it on a Monday. So it's non-emergent at this point. Now, the last lethal, third degree, that's a pain. Ashley knows about third degree. Third degree, I'm just gonna do this. It's easier. Okay, there's a QRS behind the TV. Third degree, you can just tell the PRs, not the same. I might have drew it like it's the same, but PRs, not the same. Different every time. The P waves for QRS, this one does. Sorry. No. There is not a P wave for every QRS. No. Is there a QRS for every P wave? There's no P waves around this QRS. Nope. Maybe. Nope. So no. These P waves don't have QRSs. It's missing. The next thing you look at is obviously PR. Okay, you can't because not all P waves have QRS. But you start looking at the rate, the R to R. R to R is typically regular. Because what is this patient living off of right now? Living off the Purkinje fibers. This heart rate for this patient is very sick, septic, cardiac heart failure. They need to be bolused with fluids because they're going to have low blood pressure. Atropine, I've never seen it work in a third degree, but they give it anyways. They need a pacemaker. So if this happens on a Friday, they'll be doing it Friday night. This is an emergency. Now, I have seen physicians say, no, I'll do it on Monday. But yeah. So what do? You externally pace them until Monday? This patient's living off of a pacemaker, either the Purkinje fibers or the patch you have on their chest. I've only ever had one patient with this, and he went to EP lab for a pacemaker. So, this is 3rd degree. Those are your blocks. So, everything is abnormal. Abnormal, everything. You have your P waves, you have your QRSs, you might have T waves. You know, it looks like, oh, this is sinus. Nope. Measure your PRs, they don't match out. P for every QRS, nope. QRS for every P wave, nope. The R to R is irregular, but it's slow. Slow. This is a 3rd degree.
And sometimes your P waves will be similar and your QRS will be similar, but the QRS will only be similar to itself.
Yep.
And the P will only be similar to itself. So they're not organized together.
Yep. So some people will measure P to Ps to make sure they map out. And then they'll measure the QRSs. And that's how they'll stagger them. They'll take 2 sheets of paper, line them up. It looks like that. The telltale sign is the PR. If you just measure the PR and it's not the same everywhere, they're in a 3rd degree. PR is my favorite thing. You finish your ECG test in 2 minutes if you just look at the PR. The last thing I want to cover, because it's important with this, and I'm going to cover one more rhythm. I just thought about it. Because we will cover this. Everyone does. It doesn't happen very often, but it's cool. That's why people cover it. It's called torsades. Yep. Torsades. Today, I think there's an S. Point this. It's ventricular in origin. It's not an AV block. This is a ventricular rhythm. This is VTAC of different morphologies. So it's literally going to look like this. Looks like a ribbon. With VTAC, remember VTAC? It's happening in one location. VTAC is happening at one location. Boop, 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 happening. Torsades, you have 8 or 9 locations. Boop, 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 all happening at the same time. That's why you have different morphologies. Because remember your camera, V1, V2, all that stuff? The reason why it's different is because this depolarization or impulse is going to look different to this lead versus this depolarization. Same lead, it's going to look different. Can't take the same picture from different angles. What's wrong with this patient? Magnesium. Low magnesium. That's why I wanted to cover that. Torsades, they need magnesium. And I'll just draw this little picture. You take a picture of it, whatever. This is basic physiology in 10 seconds. Sodium interacts with your P wave. Potassium interacts with your T wave. Magnesium and calcium interacts with your QRS. If you're hypernatremic, you're going to have a big P wave. Hypo, you can imagine, flattened P wave. Potassium, same principle. If you're hyperkalemic, you're going to have a tall T wave. If you're hypo, you're going to have a flat T wave. With calcium, calcium is going to do a weird thing. You can have a spike, a tall spike. You can also have this with hypertrophy, ventricular hypertrophy. You can also have it widened. So increased calcium is going to increase the sensitivity and contraction of the heart. You're going to have an increased QRS. It's going to be very tall and a little maybe wide. Low calcium, you're going to have a shorter QRS and it may be wide. Magnesium, just think hypo, torsades. Hyper, you're going to have other things going on. Might have a fast heart rate. That's about it. Supportive measures, increase sodium, lower sodium, whatever you want. Oh, this is asked on the test. I just got it, but it's good to know. Sodium potassium pump, magnesium, calcium, intramembranous activity while the sodium potassium switch. That's it. Pretty quick.
Thank you, Ian.
Yeah.
It's overwhelmed.
Yeah.
That's so impressive, you know.
I know,
Yeah.
like my heart.
Yes,
It's like, oh.
we look screwed enough this news.
Yeah. Like, after, I was like, yeah, I totally get it. And I'm like, what is even ETAC?
I hope I didn't confuse you.
No, you didn't. But it's just like, I feel like you have to, like, see them more and go over them. For me to remember. Thank you so much.
All week to remember them by Wednesday.
Right?
Oh yeah, shit. Yeah, test is next week. Yeah. So this is important stuff, obviously.
I hope you make